I think we had an empty slot. So Ansha asked me if I could fill in. And luckily, I had something on the cards that we can talk about. So we're going to talk about cardiac output monitors, but I just want to preamble that we don't have a cardiac output monitor in George Hospital. So it's maybe just good to know what is out there, what people are doing. Although having said that, we do have an ultrasound which can double up the cardiac output. So I would So I would love to have disclosures about cardiac output monitors because they're very expensive machines, and unfortunately I don't. So that would mean that someone sponsored me for some conference, which is, alas, not the case. But just going back a little bit in history, just to give you an idea about where things started. So this is a picture of Dr. Frosman. He's a German in 1929, thought it'd be an interesting idea to just see if what happens if you put a catheter up one of your veins. This is 1929, and he put the catheter all the way down. As you can see, that's an X-ray of him. I'm not sure how sterile things were in those days, but infective endocarditis probably would have been one of the options. And then injected some medication straight into his right atrium. So this is the first time that someone decided to do something crazy like that. So fast forward a little bit to 1970, and Henry Swan lived in Florida, and he basically was sitting at Laguna Beach. And I don't know if you have been there. There's a CFP about Laguna Beach also. You know, they never stop. Everyone gets a chance to have a relationship with everyone. I think it's one of those CFPs. And then he was watching. I don't know if you know, guys know what that front sail is called. Called a spinnaker. So he watched and he thought to himself, he wondered if that can be used for cardiac output, well, not really cardiac output monitoring, but to enable to get catheters into the heart. So he teamed up with I don't remember what his first name was, Gans, and this is where the Swan Gans catheter came from. So I don't know if you've had experience with the Swan Gans catheter. I've used it a few times, but it is how can I say, cumbersome. Because really the idea with it is that you put a catheter into the right atrium, and then you have a little balloon at the end. And that's where you got the idea from the spinnaker. You inflate the balloon, and then it drifts to the top part of your heart. And then if you advance it, you can hopefully get into the right ventricle, the right ventricle, and then up into the pulmonary arteries. And that's how they got to being able to measure the pulmonary artery pressure. And then from that, it's progressed into what we call the Swan-Ganz pulmonary artery catheter, but then also being able to monitor all your cardiac indices from that pulmonary artery catheter. So is the Swan dead? Have any of you seen any Swan-Ganz catheters being used, even you that were fresh in medical school? Anyone? No? So it's not really being used at all at the moment. There's a few reasons for it. It's very invasive, and to float the pulmonary artery, or the catheter into the right pulmonary artery, or any of the pulmonary arteries for that matter, isn't that simple. So it's got a bit of technical ability, and so that makes it a little bit more cumbersome to use. So I think we've really moved on from there, and we're quickly going to do a quiz because there's a lot of numbers that gets flashed by these machines that we just need to have an idea what they are. So Flo, can we start with you? Let's start there right at the top. That do or don't do. What do you think that means? Good one. So that we can actually measure the amount of oxygen that gets delivered to the tissue. Now, as we know with a lot of things, just because you give oxygen doesn't make the patient better necessarily. So more isn't necessarily good. So higher blood pressure in ICU isn't necessarily making you better. More oxygen or whatever doesn't make you better. So, but we can measure that. Okay, who's next? Liam? We're going right, we're going clockwise. Yeah, so that's ejection fraction. So Ejection fraction is basically a measurement of your left ventricular function, but it's it's not something that's a dynamic measure. So normally we do it with the echo and so forth, but there are other things that we use to measure the left ventricular output. Okay, next. Okay. Yeah, what do you think? Who knows? Nice one, yeah. So it's stroke volume variation. So with the cardiac output monitor, you can measure exactly what the stroke volume is. And because the patient's breathing, the right-sided pressures vary with inspiration because your intrathoracic pressure goes up and down as you're breathing. So that will then make it change the stroke volume. And the way that the stroke volume varies is a measurement that we can use to give us an idea about fluid responsiveness. So that's what that means. Right, Anna? Yeah, so the peripheral vascular resistance. So that's another index that we use that we can measure and say, but how vasoconstricted are that? And how good do you guys think are we at having an idea about, oof, that patient's a bit clamped down, ooh, he feels a bit hot. How good do you think we are clinically to assess that? Mild, moderate, severe, or good, bad, ugly? It depends if it's 2 o'clock in the morning. Yeah. Yeah. But the gray areas. Like the ICU patient generally are those that are like, oof, not quite sure. Are they septic? Are they not? I mean, you're right. If you come in with pulmonary edema and you're sweating, you're ice cold, look, your systemic vascular resistance is going to be high. You don't need a brain surgery. Just like, when a patient looks like biltong, you don't need a central venous pressure to tell you that. So at the extremes, we're probably good, but in the in-between, we're probably not as good as we think we are. Right, who's next? Dean? EI? CIA?
EI. Also, not for CIS.
Cardiac index. Okay. So why do we use? Does anyone have an idea what cardiac index is? So the next one maybe run. So cardiac output. So cardiac output is a measurement, but that's dependent on your patient, isn't it? So you've got a big, small patient. So it gives you your cardiac output, but you don't know what it is in relation to. So that's why people started using the cardiac index to standardize it. So cardiac index got to do with total surface area. So you take the patient's height and weight, I think, and then you make a measurement, and that will standardize it to people. So 50-year-old granny versus a 110 kilogram pregnant patient. Oh, well, there's not good pregnancy in there. That messes up everything. So that you can standardize it. Because clearly the cardiac output for a 20-year-old versus a 50-year-old is going to be different. So that's what cardiac index has been used to just standardize things. Right. So Vessel, stroke volume, and then you're going to have to tell me also what are the 3 things that influence the stroke volume. Good. Okay. So that we can always have a bit of an idea about, but they're a little bit more difficult to measure. We can't measure contractility. What we measure ejection fraction and kind of. So the stuff that is not that easy to measure. Who wants to go for that one, Luvo? The last one is for you. Oh no, second last one. Huh? I don't think the guys on the left are going to help you with that one. So that's a very difficult one. No offense, but. Okay, so that's the
external
weight
index.
Weight. So this is the extravascular lung water index. So now the cardiac monitors can actually measure how much water there are in your lungs, which is actually quite interesting because we always worried about they're becoming puffy. Is this and how puffy are the lungs? So now we can actually measure how much water is in the lungs, and it's also an index. There's one more, Nico. No. Take pulse pressure variation. Okay. So pulse pressure variation, you just need an A line for that. And that gives you the difference of your pulse pressure. And the idea with that is again, yeah, I'm recording. I'm being transcribed also. Lots. So as you breathe, your intrathoracic pressure changes. So that means your right atrial pressure changes. And with that change, it influences your preload on your left ventricle, and therefore your pulse pressure changes as you breathe. So that's what we call the swinging of the A line type of thing in layman's term. But at least now you can put a number to that, and that's a percentage. Now on our monitors, you'll see it says it's next to the A line. I've set all of them for pulse pressure variation, although there's systolic pressure variation also. They're not too different. Systolic is literally just what are the systolics doing over a 1 minute or 5 minute period. Okay, good. I think you passed. 90%.
Pressure variation and stroke volume variation.
So pulse pressure is your blood pressure, basically, that varies. While stroke volume actually measures your stroke volume is, say, 55 mils, and how much it varies as the heart beats and as you're breathing. So that's basically what it means. Yeah. Right. So there's a lot of numbers that we don't really use a lot. Okay. So I just want to show you how cardiac output monitors are divided up, and it's probably, I think for if you're doing intermediate exams, I think it's probably you got to have an idea about how these things are divided up. So the first is the Fick principle. So the Fick principle is that you use some marker in the blood and see how it dilutes as the blood goes around, and that dilution you can use as an equation to figure out how quickly the blood basically moves through the body. Okay, so that's a Fick principle. So a lot of I'll show you which monitors use that principle. Then there's pulse contour based hemodynamic monitors. So what they're doing, basically in layman's terms, what it means, they take the area under the curve of your A line and they use the pulse contour and they try and predict what all your measurements are. But they obviously, we'll get to why they are not always that accurate, as you can imagine. Patients with AF always, and the A line, and also interestingly enough, you'd be surprised what the difference is. We don't do that, but what is the difference between a radial A line and a femoral A line? There is a slight difference between the two. Then the next one are Dopplers, and I'll just, I don't know if any of you used it, esophageal Doppler, but we'll get to that. And the last one is bioreactance monitors, and we'll get to that. So that's basically how they divide it up. Okay, so and further, they just also divided into invasive and non-invasive cardiac output monitors. So the first one, I don't know if anyone of you come across the LitCo system. So basically for that, you need an A line, and it's the reason why it's called LitCo, it's lithium dilution. So it's a bit of a hack. So it uses the pulse contour, but you've got to calibrate it. So what you do is you take, I can't remember what lithium it is, lithium something. You inject it into the central line, and then it's measured when it comes out the A line. So again, it's using fixed principle to predict how quickly that concentration of lithium, as you inject it, goes down, and once it gets to the A line, how quickly that dissipates. So it uses that principle to calibrate it, and then it uses the pulse contour to give you all the measurements that you use. The next one is called the PICO. I don't know if anyone you come across it. And basically what it uses thermodilution. So you take an ice cold bucket with ice cold water, and then you inject it into the central line, and it measures again how quickly the temperature changes from, I think it's 4 degrees that we normally have. It's usually the fluid is sitting in the ice bucket, and then it measures the change in the temperature from when you inject it until it gets to the A line. So again, it uses that as a calibration method, and then relies on the pulse contour to then give you your dynamic measurements. Okay. Next one is the flow track. Now, Edwards made this, and they basically rely on your pulse contour. So they are quite easy to use because you literally just plug it into your A line. But you're going to have to put in all the indices of the patients, and it then uses, patient dynamics like height, weight, and all of other things. It has to predict what the average size of the aorta is also. So it uses all those things together. It's quite complicated, but then uses the pulse contour to give you all your measurements. So that's the flow track. I think Critiscue uses the flow track. The PICO is quite popular more in the pediatric world, but I haven't yeah, I think Red Cross has a few of them, but certainly Presidio has flow tracks. Okay, then we get to the Swan-Ganz monitor, which I've showed you earlier. So because you've got the right pulmonary artery pressure, it's probably one of the most accurate, and a lot of the studies that's been done around cardiac output monitors, they use the Swan-Ganz catheter or the PA catheter monitor as the gold standard. Of course, it's not 100%. So whenever you use something that's not 100% accurate, and you compare something to that, then you just got to put it in context. But most of the studies just compare other monitors to that because it is still considered the gold standard for cardiac output monitors. So, esophageal Doppler, if any of you used it, but basically it's a esophageal probe, single use, goes down the NG and it sits behind the heart, and it basically measures the flow through the aorta. It's a bit fiddly, so it uses the volume time integral. It's a VTI. If you do ultrasound a lot, you know what that means, but how quickly the flow goes through the aorta. And again, it has to use a lot of patient information like height, weight, male, female, to then quantify. And I think maybe just on the side, I think probably the absolute values are maybe not as important as the change in values. So when we do something, we give a fluid bolus, what is the impact on that? It probably gives us a better idea rather than if I say to you, the stroke volume is 55 mils. That doesn't really mean a lot, but it does mean something when I give a fluid bolus and the stroke volume goes up to 80 mils. Then you know that patient fluid responsive. So I think, absolute value is probably not as important as the changes in values. So that's an esophageal Doppler. And then I want to show you this picture. Now, this is Edwards' latest cardiac output monitor. This is probably the monitor that gives you the most information, but more information, it's like more oxygen, doesn't make you better necessarily. So on that, you'll see there's that extravascular lung water index. So it tells you how much your patients are drowning, and then gives you all your other indices, stroke volume variation. It also actually has, if you see at the left bottom corner, it says SCVO2. Okay, does anyone have idea what that is? So that is the central venous saturation. So the catheter has a saturation monitor in the actual catheter. So you can actually measure the central venous oxygenation. So what we do in practice is that we take a blood gas from a central line, and there's a SATs on that. And that's actually it's really called your central venous oxygenation. The reason why it got a bit of people know about that is because of the River sepsis trial. They used central venous saturation as a measurement for resuscitation. You can remember it's a trial from 2003, early goal-directed therapy. So it's a super complicated machine that gives you lots of different numbers. Oh, just quickly to non-invasive cardiac output monitors. So this is the NICOM. So this is a bioreactance monitor. So basically what it does, you've got 4 electrodes that you put on the chest. And what it does is it sends hundreds of electrical signals through the chest. And basically what it does, it measures how much water there is in your chest, beat to beat. So as the heart contracts, there's less because the blood goes out and the heart is smaller. And it measures the change in that. And that can give you your stroke volume and all your other indices. Plus, you've got to put in all the patient information. So it sounds quite nice because you literally just plug it on there and it gives you numbers. It has been, obviously the guys that manufacture it say it's amazing. But when you compare it to the Swan-Ganz, it's not bad. So the fact that it's non-invasive makes it quite easy to use. But of course, they make their money with the electrodes. So they were happy to give you the machine. We had one when I was working in Edendale, but you got to pay for those little stickers. Yeah, so that's where they make the money in the end of the day. So that's the NICOM. And then, of course, the ultrasound. I think to actually you can get all those things with an ultrasound, apart from a systemic vascular resistance. But stroke volume, obviously ejection fraction, a lot of other those things you can actually get from ultrasound. It's quite cumbersome because it's quite dependent on your views. and to reliably do it. So I do it, and then I give a fluid bolus. Now I have to come back with the machine and have a look and see it. So practically, it's not always that practical. I think the echo is probably more useful when we just look at the heart to get an idea about what's the heart doing now, or maybe, in 6 hours. But I see I'm doing a talk on point of care ultrasound in ICU. So then we'll get a little bit into more of the advanced stuff like the VEXUS protocol. It looks at hemodynamic flow within organs, not just the heart, but that's for another time. Right, and another machine that is used for the USCOM, and basically it's a little probe. It's probably this big that you literally just put here in the suprasternal notch, and it looks down at the aortic outflow, and it uses that again as to measure the flow and can measure the stroke volume and all the other indices. It's obviously user dependent, and you need to get a relatively good view of the ascending aorta, but it's relatively accurate, and again, it's easy to use. You can use it pre-op, post-op, just to get an idea. But I must say, it's not that popular, and I think also because you buy the machine and there's no consumables, so I think there's not that much money in this type of product where you just buy one and then everyone uses it.
Is this ultrasound?
It's ultrasound, yeah. It's similar to the esophageal Doppler, but I mean you're using the suprasternal notch. And then some of the more fancy ones, this is called the Litco Rapide, and basically it sounds like voodoo, I have to say. The first time I saw it, I think, no ways. It's got two little cuffs on your two fingers. Can you believe it? Yeah. Honestly, it sounds like voodoo. And basically it inflates and deflates, and it measures basically the blood pressure in the fingers, but it's calibrated to your normal blood pressure. So with that change in pressures the whole time, it can actually give you relatively accurate things. It's quite popular with anesthetists because, of course, you don't need an A-line for this, and you can play around with it. So that's maybe one of the more fancy ones that are around. But again, the accuracy is a bit questionable when you really want to get to accurate numbers. But as I said previously, probably the change is more important than the actual numbers. Okay, so what do I care? I don't know if any of you remember this guy. It seems like, I don't know if the house is still running. Huh? Oh, this is Scrubs. That's true. My word. Well, that's definitely not running anymore, I think. So do we care about these things? Are they important to us? What do you guys think? Luba? It's a rhetorical question. Otherwise, we'd have them everywhere. But if they were so amazing, we'd have them everywhere, wouldn't we? And I think there's a problem with a lot of the cardiac output monitors. It's the same as, it's like Spider-Man says, with great power comes great responsibility. So when a thing throws a lot of numbers at you, you don't know what to do with it, it's not going to make a difference to your patient. So it's really about how do we interact with these machines. I mean, we can close our eyes and just hope for the best, of course, which we oftentimes do, and think, oh, is this patient fluid overloaded, depleted? Are they vasodilated? How's the heart? Do you think there's a good, the pulse feels good or bad? Yeah, that's a blind leading the blind. So it's really how we interact with these things that really makes a difference. But the bottom line is there isn't very convincing evidence that just because you apply a monitor to a patient, they suddenly get better. And I think we understand that. It needs someone on the other side to interpret the findings and see how can we use these things. Now, where does it leave us? Because we don't really have a lot of technology with us. But I have to say, the talk is not about fluid responsiveness. That's maybe something for another time. But, with pulse pressure variation, ultrasound, we can probably get a good idea about where we need to be and where we are. So it's not all in vain. But I don't think the cardiac output monitors are really going to, come into play in a lot of different areas. I think also because of the availability of ultrasound, giving you an idea, I think probably in the future, we're not going to see cardiac output monitors hitting George anytime soon. Sorry to disappoint you. Thank you. That's it. Any questions? Yeah.
Some of them. How do you make the decision for who gets monitored? Like, who would you monitor?
Yeah, it's a good
Like,
question,
all the
Anna.
patients have got issues. It's not like, oh, we're trying to
They've got
find,
issues.
even if it's not a cardiac problem, they're going to have
Yeah.
things that impact that.
Yeah.
So how do you say yes for you?
Yeah, look, I think it's maybe a question for them. I mean, just telling from experience, working at Gray's ICU is that it was those patients where you're not sure what's going on, where you apply it, because you don't just put it on everyone. I think there's so much cost and we're conscious about cost. So I think also Credit does the same. And I think people have moved or have gone over that honeymoon phase of, oh, let's just slap on a cardiac output monitor, makes the patient better, understanding that probably, that in itself doesn't make a difference. So I think, Anna, I think the short answer is, I think there are selected patients that I think it does help us when we're not sure what's going on, and you'll be surprised sometimes that you think like, oh, but this is high output, this is vasodilated patient, and you see, and you put on the cardiac output and you think, actually, no, it's not. Probably there's a cardiac dysfunction also, but then you think, but I could have echoed the patient and also got that answer. So yeah, it's a difficult one. I think there's money to be made, and that's why these things have been promoted a lot. But yeah, I think it needs a brain on the other side.
What is a problem?
But we'll cover fluid responsiveness later on, just so we have an idea. But what do we actually do? And I think from an EC point of view, also, it's difficult sometimes to know what to do. But I think this is where the ultrasound really helps you when you're not sure: is this pulmonary edema? Is it cardiac? Yes or no? Is the patient vasodilated? What does the IVC look like? All those things really help you to get an idea about what's going on with your patient.